Without further ado, we will move on to our last speaker, who is Professor Lara Fairall, and she is the founding director of the Knowledge Translation Unit at the University of Cape Town and Professor of Global Healthcare Delivery at King's College London. The KTU are developers of the Practical Approach to Care Kit, or PAC, which supports provision of evidence-informed primary care in low and middle-income countries and has been implemented at scale in South Africa and Ethiopia and piloted in Nigeria and Botswana, and is being scaled up in Brazil and Indonesia. Lara has an interest in knowledge translation, clinical decision support tools, and their role in health system strengthening and implementation research. Professor Fairall, you have the floor.
Thank you, Lawrence, and really good to be here, and thank you very much to the organizers for allowing this opportunity to share our work with you, and I do so very much on behalf of my team at the Knowledge Translation Unit in Cape Town, several of whom are here, and also to acknowledge our collaborators from Brazil who are also here, and the leadership of Dr. Ronaldo Zonto. Nice to see you, Ronaldo. So the problem that we've been focused on for the last 20 years or so is that there is way too much information now, and the people who expected to translate that into practice are faced with longer and longer piles of information. And that's not a tower of primary studies or even systematic reviews that I'm standing next to. That's a tower of guidelines. So we may need to revisit not only how we publish results in peer-reviewed journals, but how we publish guidelines. And that is a tower of only WHO's guidelines, only guidelines restricted to adults, and only for primary care. So that's not from anyone else, that's not for children, and that's not for hospital-based care. That's too much to read. And I want to suggest that perhaps no one is reading that, with the exception of our small team. And certainly the people who should not be reading it are the healthcare workers who face the scenario that you see on the right of that slide, which are rooms filled with lots of patients, with lots of problems, and thousands of PICOs every day, day on day, and are faced and tasked with this impossible task of trying to implement this new evidence into action. Our work has been very much inspired by the knowledge translation work that was really pioneered in Canada, and this is our favorite framework at the KTU, and the reason it's our favorite framework is because of the triangle in the middle, which really makes very clear the difference in generations between different types of knowledge. And we focus very much on the tiny little tip of that iceberg, that upside-down iceberg, which is the third generation knowledge, which is not guidelines or systematic reviews, but rather the tools that health workers and policymakers need to actually translate all this knowledge into actual changes and actions and what people receive when they go for healthcare. We have our roots in a WHO program, the Practical Approach to Lung Health, which started in the late 1990s and early 2000s in an attempt to streamline and simplify care for people who present with respiratory symptoms to primary care. And that really turned out to be a bit of a proverbial snowball, and our development has been very much guided by the needs of frontline health workers with whom we work on the front line, who can have no favorite disease, who can have not examine only one PICO, but who have to deal with a multitude of problems and issues and social dimensions in the people whom they serve. It's expanded now to be a comprehensive package across the life course for all patients presenting to primary healthcare facilities in LMICs. And it's been a great privilege of my career and of my teams to work in many different countries and contexts. It's been scaled and sustained in South Africa for the last 10 years to nurses and doctors who work in more than 3,500 primary care facilities. And a localization of it has been scaled in Ethiopia, also to 3,500 facilities. It's currently under Dr. Zonta's leadership, being scaled up in Brazil, and it's been piloted in multiple states in Nigeria, and is now currently being rolled out in a pilot in Indonesia, which Indonesia style is in fact 10,000 facilities, just the pilot. So at the heart of this program is a tool, a very simple tool, which brings together all these guidelines. So not only the WHO guidelines, but also the local equivalents of these guidelines, which are also many thousands of pages, and tries to summarize them into the way that people present to primary care, which is either with symptoms, and long-term health conditions of conditions they've already been diagnosed with, and they're coming for repeated planned care. And we have no favorite disease at the KTU, so whether a condition is a non-communicable disease or a communicable disease, or whether it's an episode like pregnancy or tuberculosis, we'll deal with them in exactly the same way, because these are all people who required planned, frequent, regular attendance in primary care. And every page of this decision support tool is structured in a very simple way. So all the symptoms contain a red box, which deal with all the red flags that need to identify people who are best managed at a different level of care, and so need to be identified, stabilized, and then transferred. For long-term health conditions, we have a very simple framework that we've applied across 26 conditions, which includes assess, advise, and treat. So given that this is an evidence summit, I'd like to really reflect on 3 elements of our program that are inspired by and really try to promote engagement with evidence between multiple stakeholders in our health systems. The first is that the program that we are responsible for designing in partnership with our collaborators at Ministries of Health and implementing many hard hours and many miles crossed to clinics all over South Africa and other countries is very much informed by the work of the global evidence community and around evidence-based methods for implementation. Here is a picture of some of the trainings that happen, and you'll see that these trainings are in person and in groups of healthcare workers, because most healthcare workers in the world actually work in teams, and it turns out they'd like to be trained in those teams together. So we have designed an interactive training program that goes through case scenarios that's very much informed by an evidence-based implementation strategy called educational outreach, and that includes collaborative problem solving. So they manage cases, and then they also discuss real-life examples of people they've struggled to manage in those facilities and how best to do that next time. This is implemented by a large network of facility trainers and champions who really are encouraged to adopt methods of supportive supervision in these discussions, provide non-judgmental spaces for clinicians to discuss both their successes and their failures in managing patients. And it is sustained over time. So while I would really like to see a reduction in the number of guidelines that come out every year, and perhaps a simplification of those, it's really important that they continue to come out, because it is that a continued publication that brings life and sustained change and drives ongoing scale-up of these programs. So the byline of the summit is around using evidence to improve lives. Now, you cannot do that unless you go to scale. And that really means that you have to let go of your beautifully designed programs under ideal conditions and do things in the real world, often imperfectly. But it really is important to scale them. And so we've been really fortunate to have spent the last decade learning more about how to do that effectively in 2 particular countries, in South Africa and Ethiopia, and now in Brazil, and applying that to scale up in different contexts. And to the point, it is very different in different countries. There's a culture of scaling and of how evidence moves into practice. So during the pandemic, we were forced to fast-track the implementation of our online training program. And what I want to really point out with these pictures here is, can you see that even though this is obviously during the pandemic because health workers are wearing their masks, they're still in groups, okay? So even though they're engaging with the content on their individual devices, they still prefer to work in teams to try and solve health system problems and work out how to action this evidence into practice. Over time, we've turned this lens of evidence on ourselves. And as funding has permitted, we have evaluated additional increases or changes in scope, or task sharing, or going to different ages, like to children and to adolescents, or to different problems, like the emerging problem of multimorbidity, using a range of implementation studies and pragmatic trials. And the reason we do this is because it keeps us extremely humble, and it is a really stark reminder of just how extraordinarily difficult it is to change these complex health systems and to improve practice. And so this is really a summary of some of the results from these studies, which have shown small improvements, but across a range of outcomes and behaviors in the range that we do see in implementation science trials. And these behaviors include behaviors like prescribing, referral, case detection, and increasing access to evidence-based treatments for the thousands of patients who attend primary care facilities and LMICs. I also want to point out that it's not always even successful. So in the context, there is no magic bullet for implementing evidence into practice. And in the context of depression case detection, for example, where if only it took 17 years to implement evidence into practice. And in South Africa, less than 1% of people who live with depression have access to effective treatments in the public health sector. Without changing the structural problems in which nurses are not allowed to prescribe antidepressants, and there are no counselors available to deliver effective depression counseling, an approach like this was not able to make a positive impact on that. Incentives have been a real theme of the conference, and I want to share this photo because, in fact, this is the incentive that motivates us. Okay, we're not that big on publications in our unit, but what we really are big on is this: is this is a nurse working in Northwest, which is the province of South Africa in the north that is closest to Botswana. This is an early winter's morning, and around about 7 o'clock in the morning, and going into her room and seeing that she doesn't have any guideline on her desk, but she does have a version of our program on her desk that she's using to manage patients. And that really, for us, is the incentive that drives us, that we're able to equip and support these health workers to provide more evidence-based care to the people they serve, and that we're able to also contain their anxiety and their fears. It's really scary to face rooms of patients like that every day. It's really scary for people to die in front of you. And these people need support, and they go back day after day. And really the work that we do is really motivated by being able to do that. So I want to change track quickly, because I see time is not with me, and just take you into the back end of what supports our program, which is really an evidence database underpinning all the recommendations contained in the guide. So here's an example of one of our pages, and you can see the little black dots there with numbers in them. Those correspond to recommendations, not to PICOs, not to things for which there is evidence, but to every single clinical decision that people have to make when they actually manage a person in front of them. And these we have summarized and moved into a vectorized database in which we have linked to all the sources from which they are drawn. And so in one of our clinical decision support tools, there are more than 3,500 recommendations linked to 100,000 sources. So like many of you, we are looking at new technologies to enable us to get through that pile faster. So we've implemented an implementation of a large language model combined with retrieval augmented generation to see whether we can try and identify what is changing on a fast-track basis so that we can update our content quickly and also support localizations in other settings. So here is an example that I know is of interest to our national department at the moment. I'm looking at you, Tamara, which is around what actually is the target A1C for diabetes. These are some of the guidelines that she would need to consult. You see, she would need to do a lot of reading. There are lots of hundreds of pages. So we've imported them into the database. We've split them up into individual pages, and we've instructed the large language model, in this case, OpenAI or ChatGPT, to read them for us. And here you can see that we asked our database this question, and it was able to quickly help identify which pages for a clinical editor to go and look at. So this is certainly nowhere near ready to be used widely, and it's nowhere near ready to be used by clinicians, but it is something that we're hoping will try and expedite and fast-track this gap between all this information and practice. So this is a blatant advert because I think one of the big issues that we've come across in our work in LMICs is that when guidelines are produced after really months and months of detailed evidence synthesis, sometimes years, in fact generally years, and are finally approved, they do not enter into a vacuum. In all the countries of the world in which we have worked, no matter how poorly resourced, there are hundreds of guidelines existing in those countries that govern the current package of care that is provided to people and the way that people see patients. And so we've started assembling this because what we are finding is that in these different countries, people are going through the same different kinds of discussions about how to fit perfect evidence to imperfect and low resource settings. And that this is duplicating effort, which is often not recorded or shared, and could be shared to fast-track these processes. We're aware of several groups who are collating and mapping guidelines in different countries, and we'd really like to invite you to join us in this process to summarize this. And I'd really like to see a large language model that is trained on global South data. So this is an unintended consequence of our work, which is that I never imagined when we started out on this journey that a clinical decision support tool will be used for policy making. But in fact, it turns out that not only clinicians lack the time to read the guidelines, but so do the policymakers. So in fact, we have been using this and more intentionally now, to structure conversations and engagement with evidence dialogue between different stakeholders in health systems. So here is an example from one of our current guides, and 7 words as to whether or not to screen for hepatitis B in pregnancy in South Africa. So when we look at our own culture of guidelines or our own repository of guidelines in our country, we have varying recommendations regarding this. We have one state-of-the-art guideline pre-pandemic which recommends this. We have a national indicator added in 2023. And we have 3 guidelines published between those periods that conveniently don't even mention hepatitis B screening, not whether you should do it or whether you shouldn't do it. And in fact, these are complex decisions because to trigger hepatitis B screening in pregnancy would trigger enormous costs for the health system, whether to top up vaccinations for women who screen negative or whether to route them to specialists for treatment if they screen positive. And so these are complex decisions, and they need time to be engaged at a national decision-making level. They need budget impact analyses often to make these decisions. But what we want to really try and communicate to health workers is that those conversations are not their responsibility. Those conversations must happen at a national policy level, and we need to just really contain them and tell them what they should be doing in the meantime. And finally, I just want to leave you with this reflection. I think this is something that's come up a lot in the talks and in the conference in general, is that really this process of evidence synthesis and engagement and getting evidence into practice is about one thing, and that's about people. And it's really about building relationships between multiple diverse stakeholders and really about amplifying voices across that. As people who work in evidence synthesis, we're incredibly privileged to be able to access both policymakers, people with lived experience, and providers. And it's our responsibility not only to share evidence, but to amplify voices. We're trying to work out in my team how to do that better with people with lived experience. And so this is a group of people who are living with multi-morbidity in South Africa, who we're working with really closely to make sure that the work that we develop is better suited for what they need. And finally, just to end with this quote from a recent paper around learning health systems, which really drives home this point that our most valuable asset in getting evidence into practice and in learning health systems and improving health systems is really human and relationship capital. So you need to have the coffee, you need to drink the wine, you need to talk to each other and develop those relationships. So just to thank my team from all corners of the world, as well as just to highlight some additional sessions that are coming up, including one at 5 o'clock this afternoon, which I'm reliably informed is on the other side of the bar, to learn more about PAC if you are interested, and then to hear from our Brazilian team tomorrow around their experience. Thank you.